Hi. First of all, I want to thank the colleagues at the US satellite of Cochrane Vision for asking me to present these slides. Let me introduce myself as an ophthalmologist with epidemiology training, a Cochrane author since 2002, editor since 2005, and coordinating editor of the Diagnostic Test Accuracy Satellite of Eyes and Vision in Florence since 2011. Tianjin asked me to present an introduction to systematic reviews. A systematic review uses explicit methods to identify primary studies, select those that fit inclusion criteria, appraise their quality, and synthesize results from studies that have compared similar interventions and measured the same outcomes. Meta-analysis is the statistical technique used to combine studies and is usually a component of a systematic review. The methods used for each step of the review are pre-specified in a protocol. As you may know, the Cochrane is a non-profit organization and a developer of methods for evidence synthesis for healthcare decision-making. Cochrane groups publish their protocols and reviews in the Cochrane Library. Health information is massively represented on the internet, and both the public and health professionals may find it difficult to decide what treatments are more effective and safe when multiple options are available for the same problem. These are examples of health questions regarding lifestyles. The question regarding potential benefits of low-dose alcohol consumption has been investigated in several studies, which show the potential cardiovascular protective effect of small doses of alcohol, especially red wine. However, a dose-response pattern was not consistent across studies, and some found that even low levels of alcohol consumption were not safe or beneficial. This means that the evidence was very heterogeneous on this topic. When a study is published, readers should be aware that its results are incremental to all the previous evidence. A systematic review is a comprehensive assessment of multiple studies on the same research question and provides the whole picture on this question. Typical clinical questions include the interventions compared, for example, yoga as the treatment of interest in this slide, a few outcomes that are important to patients with a given condition, such as quality of life, and the condition itself, breast cancer. A comparison can be conducted not only with other interventions, but also with different timing or doses of the same intervention. Some reviews may focus on adverse effects of interventions, for example, in vitro fertilization as a potential cause of breast cancer, or focus on exposure to chemicals rather than drugs. Questions outside medicine have also been studied with systematic review methodology. There are many methodological challenges to be faced in the application of systematic reviews outside clinical specialties. For example, there may be difficulties in incorporating appropriate contextual information and in incorporating the results of relevant qualitative research. Most of all, there may be problems relating to the identification of unpublished studies and grey literature. These problems are also common in reviews of healthcare interventions and do not preclude the use of systematic review methods. As a matter of fact, methods for systematic reviews in healthcare have been developed for study designs other than randomized controlled trials, particularly prognostic and diagnostic studies, and methods are also available to appraise and summarize qualitative evidence. Regarding the review of the evidence on yoga in women with breast cancer, this slide presents the results as a plain language summary, which is a narrative synthesis of the evidence found, as well as its quality, using non-technical words. You will be already familiar with this figure presenting the study flow in a systematic review. The initial selection is based on title and abstract, followed by the retrieval of relevant full texts. Searches usually include grey literature, such as conference proceedings, and institutional repositories, such as FDA files, are also searched when treatments are drugs. The reference list of relevant full texts is also scanned. Each step should be performed blindly by 2 reviewers to ensure the consistency of the searches and data abstraction. The methodological quality of each study is appraised and presented for each domain of the Cochrane Risk of Bias tool. The Risk of Bias tool used in this figure is version 1 and is being gradually replaced by the 2.0 version. The domains of the current tool are the following: how the randomization sequence was generated and then concealed to the study personnel until the participant was included. This is important to ensure that allocation is truly random. Another domain is masking to randomization status of participants, personnel, and outcome assessors. While masking of participants may be impossible for certain treatments, such as surgery or rehabilitation, masking of outcome assessors can generally be accomplished also for subjective outcomes. For example, using video or audio recordings of interviews. Masking may not be an issue when outcomes are objective, for example, glycated hemoglobin. The judgment on missing data and losses to follow-up must take into account the amount, but also the causes of missing data. Bias due to missing data is more dangerous with rare events, such as adverse events. Publication bias, the failure to publish non-significant results from small studies, is only one type of bias in the reporting biases domain. For example, this includes biases introduced by deviating from the study protocol or manipulating outcome measures or choice of outcomes. Finally, other biases may include important baseline imbalances in confounders or biases specific to unusual study designs, such as crossover studies. The main output of a meta-analysis is a forest plot, which you see here. When the effects found in individual studies are pooled, each study is weighted according to its precision, which is displayed as the size of the central green square here, and is also inversely related to the width of the horizontal line of the 95% confidence interval. When the horizontal line of each study crosses the vertical line of equivalence or no difference between the treatments compared, then no statistically significant difference is detected for that study. The meta-analytic or pooled estimate is shown as a diamond at the bottom of the plot, and again its width is the 95% confidence interval. This is a summary of findings table or SOF, which shows the key results of a systematic review in a succinct way. One SOF is prepared for each main comparison, in this case yoga versus no therapy for women with breast cancer. Up to 7 outcomes are presented in a SOF, which are critical from the patient's perspective and should include at least one type of adverse event. The summary of findings table commonly shows the effect in the control group and the difference with the experimental group with its 95% confidence interval. The number of studies and patients for each outcome are also presented. Finally, the quality or certainty of the evidence for each outcome is reported, ranging from very low to high, together with the reasons for downgrading the quality as footnotes. Here you can see how literature reviews can be classified. Traditional narrative reviews summarize the whole knowledge on a disease, commonly starting with its causes and pathophysiology, including its prevalence and incidence, clinical picture, treatment, and prognosis. Systematic reviews of interventions are more focused on specific comparisons and use pre-planned and standardized methods to identify, select, appraise, and summarize studies that are similar in terms of population, intervention, and outcomes. Most systematic reviews include a meta-analysis, the statistical pooling of individual study results to obtain the pooled estimate with its uncertainty. The steps in completing a systematic review include an initial discussion to formulate the research question, which should be conducted by both clinicians and methodologists as the review team. Once the protocol has been prepared and published, searches are conducted on several databases and covering gray literature sources. Two reviewers should independently screen the titles and abstracts retrieved to ensure consistency, and then perform a data abstraction and risk of bias assessment for each study. Qualitative assessments and meta-analyses are then conducted, and the certainty of the evidence is finally assessed using the grade system. Systematic reviews are also periodically updated, depending on the evidence production on a specific clinical question of interest. Some of the current reviews of COVID-19 are called living reviews, since they are updated almost continuously. So, why are systematic reviews useful and important? The basic requirement is that they are systematic, which means they capture all high-quality studies that are relevant to the research question. If a meta-analysis is conducted, this can improve the precision of the estimates of individual studies and also show whether they are consistent or rather heterogeneous. Finally, an independent assessment is conducted of the risk of bias in each trial and overall, and this is the basis for appraising the certainty of the evidence. All this work will be available to guideline developers who prepare recommendations on clinical or public health questions. Guideline production needs more than just an evidence synthesis, since the evidence must be integrated with clinical expertise, considering patients' preferences and values, costs of interventions, how interventions can be implemented in existing clinical pathways, including feasibility and acceptability. Let me now focus on when a meta-analysis can be conducted. A meta-analysis is not always possible in a review if the evidence comes from individual trials which differ in terms of question components, time frame, or design. Thus, in this slide, both definitions focus on the similarity of the trials that are pooled. You'll see later that clinical, methodological, and statistical heterogeneity are all important to decide on the possibility of pooling trials. Here you can see in more detail the structure of a forest plot. The weight of the study is proportional to its size or precision, which is also reflected in the width of the 95% confidence interval as a horizontal line. In this graph, the point estimates of all trials lie on the vertical no difference line, and the meta-analysis diamond is more precise than each trial. The measure of effect is shown on the lower x-axis, together with a scale, and shows which direction favors one treatment option or the other. So in a systematic review, the evidence on different types of outcomes is piled up in a series of forest plots, and we will look at the most important of them to prepare a summary of findings table. We must be careful not to mix studies that are too different, as we said. When we interpret the results of systematic reviews, we have to look not only at the pooled estimate, but first of all at how many studies favor one treatment or the other, what is the size of the effect in terms of clinical importance, whether the effect estimates are very different from one another or they are similar. These are most graphical and quantitative considerations and account for domains such as precision and consistency in the grade assessment of the certainty of the evidence, which also uses the judgment on the risk of bias for all studies. A meta-analysis can help us to determine whether an effect exists in a particular direction, to obtain a single summary result, and also to examine reasons for different results among studies. Studies can be combined if they are estimating a common effect. Statistical evidence of a certain degree of heterogeneity is often found, and a decision has to be made on whether pooling is appropriate. When you consider whether studies are similar enough to be pooled, all relevant study characteristics that may be so-called effect modifiers and have been collected as part of the protocol should be considered. Mean age or any age limits used for inclusion and the severity of the condition are typically available in many studies and are important potential confounders. Differences in drug molecule or doses are also considered, as in this example of interferon use for hepatitis C. Not only the studies must have measured about the same effect, but also the measurement tools and scales should be similar across studies. In many cases, certain outcomes of interest for the reviewers are not reported, a type of reporting bias which can be confirmed if a study protocol is available. In fact, when few of the included studies report an outcome of interest, reporting biases may be detected. Reviewers should avoid mixing studies with dubious similarity or which only partly fit inclusion criteria. In such cases, a good narrative synthesis of individual studies may sometimes be better than a meta-analysis. Nonetheless, a broad scope review can be undertaken when interventions are complex and not well defined, such as rehabilitation, as this can be useful to present the overall picture of the research in a field. Meta-analysis should be interpreted with caution in these cases. At the other end of the spectrum, a cumulative meta-analysis of trials on thrombolytic therapy for acute coronary disease, a treatment which was first used in the 60s, shows how important it is that we synthesize the evidence in a timely manner. A reliable demonstration of a benefit would have been obtained in the early 70s, when in fact textbooks started to recommend thrombolytic therapy more than 10 years later. This is a famous example of how useful a timely meta-analysis can be. I am now going to present examples of partnership between Cochrane Eyes and Vision and users of systematic reviews. The American Academy of Ophthalmology updates its preferred practice patterns every 5 years. Cochrane Eyes has helped the Academy to identify and share relevant and reliable systematic reviews to inform recommendations. Cochrane Eyes has helped the Academy to update 18 out of 23 PPPs since 2015. As of March 2011, CEV at US had already published over 85 systematic reviews, including updates, and over 90 systematic review protocols. Cochrane is also in official relations with the WHO. Its funders include the NIH in the US and the NIHR in the UK. Some Cochrane Eyes reviews have had a considerable impact on global policymaking, such as that on the safety of Avastin versus Lucentis, which show that concerns regarding the systemic safety of the off-label drug bevacizumab were not based on evidence. A few slides on who the producers and users of systematic reviews are. Certainly one of the main producers, but today many authors are independent. Governmental institutions in countries such as the US, the UK and Germany also publish systematic reviews to inform national recommendations on the use of healthcare resources. Cochrane is a global independent network of researchers, professionals, patients, carers, and people interested in health, and is recognized as an international gold standard for high-quality, trusted information. The Cochrane Handbook for Systematic Reviews of Interventions offers updated guidance on methods for conducting systematic reviews and is freely available online. The Institute of Medicine also offers a free PDF book on standards for systematic reviews. More practical guidance and a checklist on editorial standards for conducting and reporting systematic reviews is found in the Masir Manual on the Cochrane website. In conclusion, in this talk I wanted to highlight the usefulness of systematic reviews which adopt pre-specified, reliable, and transparent methods to synthesize data from similar individual studies, generally including their statistical combination as a meta-analysis. Reading research is a good way of learning both contents and research methods. You can search and find what is your greater interest in the Cochrane Library.